Good morning, everyone. Welcome to the Health for the World International Grand Rounds. We are honored to have our speaker today, Dr. Judy Yi. Dr. Yi is the professor and university chair of radiology at Albert Einstein College of Medicine and Montefiore Medical Center in New York City. Dr. Yi is an internationally renowned radiologist, and we are very lucky to have her. A little bit about Dr. Yi. Dr. Yi's research focuses on colorectal cancer screening and early detection using a novel technique which she has helped to develop called virtual colonoscopy or CT colonography. Dr. Yi has published extensively, having produced more than 130 articles in peer-reviewed scientific journals with another 120 abstracts, and she has served as the principal investigator for many funded research projects. She has published 23 book chapters on the subject of gastrointestinal and abdominal radiology. Dr. Yi is also the editor and primary author of Virtual Colonoscopy, which is one of the main textbooks on the topic. Dr. Yi is a renowned woman radiology leader and holds leadership positions in major radiology organizations. She served on the board of the Society of Abdominal Radiology and was the president of SAR from 2015 to 2016. She is also a well-respected educator, having instructed and mentored numerous trainees in abdominal imaging. She is the recipient of multiple awards, including the Excellence in Teaching Award from the Academy of Medical Educators and the Visiting Professorship Award from the Society of Gastrointestinal Radiologists and the Best Speaker Award of the American Rankin Ray Society. We are honored to have Dr. Yi as a speaker today, and Dr. Yi's topic today is imaging workup of focal liver masses. Dr. Yi, you can start whenever you're ready.
Thank you. I'd like to start by thanking Dr. Rahani for the invitation to speak with you about focal liver masses. And in this talk, I will review with you features of both benign and malignant focal masses of the liver. And I hope that by the end of the talk, you will be able to use specific findings that'll help you in differentiating the various types of masses. Now, during the course of this talk, I will go through with you the differential diagnosis for fat containing, cystic, and soft tissue tumors of the liver. So in this talk, under the broad category of benign liver lesions, we will discuss developmental lesions, vascular lesions, and then tumorous lesions. We'll start off with the benign lesions, and everyone's very familiar with the hepatic cysts. As you probably know, these are developmental in origin, representing remnants of blind-ending biliary ducts lined by cuboidal epithelium. They are more common than we used to think in the past, and they're present in up to 15% of the population. When they become giant and very large, they become symptomatic, and this occurs in less than 3%. There is increasing prevalence as you get older in the age 40 and above. So it does seem to occur more commonly in older individuals. Now, there is also a female predominance. The typical appearance is as a unilocular, rounded lesion with smooth, thin, often imperceptible walls. The attenuation value on CT is typically under 20 Hounsfield units. MRI is fairly characteristic, low signal on T1 and light bulb bright on T2. And of course, they do not show any significant enhancement. You can get numerous of these lesions, and if numbering greater than 10, you have to think about polycystic liver disease. And in that setting, when you have so many of them, you may have some that will show hemorrhage or calcification. And this is just an image of a relatively small one and then a giant hepatic cyst. Again, on MR, T1, low signal intensity, light bulb bright on T2, and then post-GAD, really no significant enhancement. Multiple lesions, you're thinking about adult polycystic liver and kidney disease. Now, I think what's mostly important for us to remember is that there are mimics of cysts, and these can be benign, such as the hamartoma, hemangiomas, pseudocyst, biloma, and abscess. But cystic tumors can also simulate cysts, and these include cystic mets, biliary cystadenoma, and lymphangioma, and I have examples of that to show you. So here's a patient, and you can see several low attenuation lesions. The larger one has an irregular border, so clearly you're already suspicious. And this happened to be a cystic metastasis from pancreatic adenocarcinoma, but you can see how low attenuation the lesion is. Here's another patient with at least two hypodense lesions. And here it is on ultrasound with arrows. You can see that this is not a cyst. In fact, there are echoes that fill this particular lesion, and these turned out to be metastases from a mucinous colorectal carcinoma. What about this patient? You can see at least two hypodense lesions on CT. They're fairly small. Well, these were sort of called too small to characterize. And on follow-up, you can see the anterior lesion has significantly increased in size, whereas the posterior lesion shows no change at all. So this turned out to be both a metastasis from colorectal carcinoma, and that more posterior lesion was a cyst. What about this patient? Here you can see on the arterial and the portal venous phase a cystic lesion that really doesn't show much enhancement, has a fairly imperceptible wall, hypodense. You would be tempted to just call it a cyst. However, on follow-up imaging, you can see many more lesions and significant increase in size of the lesion that we saw in the prior CT with some rim enhancement. So again, this was metastatic carcinoid that on the initial scan simulated a simple hepatic cyst. Let's move on to biliary hamartoma, and there are various names for this entity called bile duct adenoma and von Meyenberg complex. These represent, again, remnants of rudimentary bile ducts. Typically, you'll see multiple of these. They are always tiny. And I have down less than or equal to 10 millimeters in size, but often they're even smaller than 5 millimeters. They are often non-enhancing. You may occasionally see a little bit of enhancement around these lesions. And I think that, you know, again, why are these lesions important is that they can be confused with multiple metastases or even microabscesses, particularly in immunocompromised patients. And this is typical appearance of biliary hamartomas, where you see innumerable tiny lesions scattered throughout the liver. And you can see many more of them typically on T2 weighted MR. So hypodense on a CT, non-enhancing on MR, low signal on T1, very bright on T2, and on ultrasound they can be hypoechoic and often are hypoechoic. Rarely they can be hyperechoic. And what's classic on ultrasound is this comet tail artifact, and I'll show you an example of that. So on MR, again, we see many more of them, T2 very bright, and here on ultrasound you can see many of them with the comet tail artifact. When you have so many of them that they really sort of overtake the liver, it produces what's called the starry sky appearance, and this is a radiology classic. So starry sky appearance, and you think of biliary hamartomas. Okay, let's move on to the vascular category. And we'll start off with what everyone's familiar with, which is the hemangioma. These are very common in up to 20% of the population. And these represent large vascular spaces that are lined by endothelial cells, and they're fed by the hepatic artery. Female predominance, and the majority are relatively smaller at under 4 centimeters. And there is a predominance for the periphery of the liver. Interesting to note that once you have one, look for others, because in up to 50%, they are multiple. Some of these lesions, and up to 20%, can have fibrosis, and calcifications occur in about 5%. So this is just to show you the ultrasound appearance. And you typically have a well-defined wall. You can see that when they're small, they're homogeneous and hyperechoic, and they may demonstrate posterior acoustic enhancement. However, when they become larger, they tend to be more heterogeneous because of fibrotic changes. And so we don't have that same sort of smooth appearance, and the wall may appear discontinuous. The enhancement is classic peripheral discontinuous nodular enhancement with centripetal fill-in. And you can see that on the image on your left, we have the peripheral puddling, and it provides that sort of discontinuous enhancing appearance. On the delayed image, the entire lesion is filled in, and in fact, one of the features is continued enhancement on the delayed image. Again, classic appearance on contrast enhanced CT, which is very sensitive and very specific, as you can see. On the non-enhanced image, the non-contrast image, you can already see a hypodense lesion, and with the peripheral discontinuous puddling on the arterial phase starts to fill in centripetal, and then with continued delayed enhancement on the later phase. And what about MRI? And has very similar enhancement pattern with the peripheral puddling and then centripetal fill-in. And you can see on T2, classic is a high signal bright lesion, T1 hypointense, typically high signal on the diffusion weighted image, and then no evidence of restriction on the ADC image. What about the appearance on using hepatocyte specific agents like Multihance, Eovist, and Primavist? And you can see very similar type enhancement pattern where on the early arterial phase, you may see some peripheral nodular enhancement, again, fairly discontinuous with centripetal fill-in as you move towards the venous, and then the delayed phase. On the 20-minute hepatobiliary phase, typical for hemangioma will be a hypointense pattern. So there is no continued enhancement. In fact, we don't want to call it washout, but note that it is hypointense on the HBP phase. Now, this is not specific for hemangioma, but can be seen with malignant lesions, hepatocellular carcinoma, as well as metastases and even dysplastic nodules. So although, given in total with the enhancement pattern, you can make the diagnosis of hemangioma, the hepatobiliary phase by itself is not specific for hemangioma. What about contrast enhanced ultrasound, which many sites are performing? You can see that you can identify the classic enhancement pattern. So some peripheral nodular enhancement and then gradual fill-in. Now here's a patient you can see with 2 lesions on the non-contrast image, and then following contrast, you can see that there is fill-in of the more anterior lesion, which was the hemangioma. The posterior lesion was a cyst. Just to point out on the non-contrast image, the cyst is actually lower attenuation than the hemangioma, and that's a tip-off for you as well. Now these lesions can grow to be quite large. This is a giant hemangioma, and again, very nicely demonstrated is that classic peripheral enhancement pattern. However, when you look at the delayed phase, you can see that there is central fill-in. However, it doesn't fill in completely, and that is very common in these giant hemangiomas where they have a central scar. And again, on MR, typical enhancement pattern On the delayed, you can see that there is gradual fill-in. The MR also nicely demonstrates on T2 weighted imaging the internal septations as well as the central scar. So use the T2 weighted images to look for both. Calcifications can occur, as I mentioned, in up to about 5% of cases. And on this CT, you can see several calcifications associated with a hemangioma. Here's another one, giant hemangioma, again, with central scar and calcification. And here is the central fill-in. Again, never fills in completely, and that's quite common. Now, again, what's very interesting is that there are lesions that can simulate hemangioma. And one that you may know of is angiosarcoma, but others can also simulate hemangioma. This includes hemangioendothelioma, metastasis from choriocarcinoma, and then various metastases following chemotherapy. And these are from primaries, including colon, breast, islet cell, and ovarian. So here's a patient with angiosarcoma. And you can see that on the arterial phase image, an enhancement pattern that really does simulate hemangioma with peripheral puddling and a discontinuous pattern. Now, a slight tip-off is that on the venous phase, there's very little fill-in, and as would be expected for the angiosarcoma, it would never completely fill in. Here's a patient with multiple lesions throughout the liver, and you can see peripheral enhancement of many of them, and these were metastases due to choriocarcinoma. Now, there's a special category of hemangiomas that can be problematic, and these are the small, what we call flash filling hemangiomas, measuring under 1.5 cm. They are flash filling because they show immediate homogeneous enhancement, and this is where it becomes a problem, is it mimics hypervascular tumors, including hepatocellular carcinoma. What can help you is that whereas HCC would show washouts, small hemangiomas would typically show delayed enhancement, and that's a differentiating factor to watch out for. Ultrasound you can use for problem solving. The appearance is of an echogenic lesion with increased through transmission, MR, T2 very bright, and again, an enhancement pattern similar to CT. So here is a small homogeneously enhancing lesion, and you can see that even on the delayed phase that there is still enhancement. Here's yet another one on MR. So low signal intensity on T1, bright on T2, not quite as light bulb bright as a cyst, but you can see that it does enhance more on the periphery, even for this small lesion. Here's yet another one. And I think that these cases, two patients, the one on top shows a small lesion, the one on the bottom shows a larger lesion, but both show that on the delayed phase, these lesions hang on to contrast. There are large vascular spaces where the contrast just pools, hang on to the contrast. So look for this persistent delayed enhancement. Okay, let's move on to a very interesting lesion that I think of as having an opposite enhancement pattern compared to hemangioma, and this is the pileosis hepatis. These are also blood-filled cystic cavities, and there are various associations to medications, including anabolic steroids, oral contraceptives, and then there is an association with immunocompromised patients, including AIDS patients. Of note, in up to about half of patients, there is no clear association. Now, these lesions show early central globular enhancement and then peripheral fill-in. So it is an opposite enhancement pattern compared to hemangioma. So the centrifugal enhancement pattern is what we expect for these lesions. In immunocompromised patients, this is called bacillary ileosis, and there's a specific rickettsial organism that has been found to cause bacillary ileosis, the Bartonella organism, and it's the same organism that causes cat scratch disease. It's important to diagnose, and often you need biopsy for the definitive diagnosis, but you must think of the lesion because it is treatable with antibiotics. And so here is a ileosis lesion, and by all means, I think all of us would call this a hemangioma, and that's fine. But you know, this actually turned out to be a ileosis lesion. These can resolve, and this lesion actually resolved on a follow-up CT. Now here's a much larger lesion, and often these ileosis lesions are quite extensive, involve the entire liver. You can see the very large size of several lesions within the liver. It can also involve the spleen as well. Note the enhancement pattern. There's really a cluster of globular enhancement located centrally. And then on the delayed phase, you can see that there is centrifugal enhancement with spread more to the periphery. So think about ileosis hepatis when you see this enhancement pattern. And here is even a more delayed phase, and you can see how it is spreading from central to the periphery. Okay, let's move on to another benign vascular lesion that we see quite often, the THAD, the transient hepatic attenuation difference. These do show up most prominently on the arterial phase. They tend to be peripheral, subcapsular, and have a wedge-shaped configuration in either lobar segmental or subsegmental territories. Various etiologies include the setting of arterial portal shunts, and these may be caused by trauma, even due to a liver biopsy, for example, due to various benign and malignant mass lesions, and even cirrhosis can be a cause of THADs. Vascular compression or anomalous vasculature can cause THADs. Inflammatory etiology, so cirrhosis itself, you know, and hepatitis can be associated with THADs, and then idiopathic. So here's a patient with clear cirrhosis, and where the yellow arrows are pointing, I think you can see it's subtle, but subcapsular, somewhat wedge-shaped enhancement. Here you can see a little bit better. This was a patient who was status post a recent liver biopsy, and again, you can see this subcapsular wedge-shaped enhancement. Remember that these are arterial phase dominant, so these are 3 different patients. These were all hemangiomas and associated with THADs. Here's a patient with a hepatocellular carcinoma, and you can see slight biliary ductal dilatation as well, but associated with a larger THAD that extends actually not only subcapsular, but all the way centrally to where the tumor is located. And part of this is likely due to some compression. Okay, moving on to the tumor category, we have these lesions that we will review. And starting off with biliary cystadenoma or carcinoma, and I have it as both because it's very hard to differentiate the cystadenoma from cystadenocarcinoma just by imaging. But these are uncommon tumors that occur in middle-aged women. Patients present with the symptoms of abdominal distension and pain, and occasionally with jaundice when they become large enough. These present as loculated cystic masses. Often they're fairly large by the time patients present. They can have an enhancing wall. Internal septations are often seen. And I think what helps to nail the diagnosis would be enhancing nodules, which are often along the wall. These lesions can also contain hemorrhage and calcifications. Again, when you see this and you think that it might be a cystadenoma or carcinoma, we can't tell the difference. They have to be resected because this diagnosis, whether it be adenoma, even they're considered pre-malignant, and when there's more internal architecture with septations and nodules, enhancement, they're more likely malignant. So here's a patient. This turned out actually, this was resected. This turned out to be benign. This was a biliary cystadenoma. You can, however, see a mildly enhancing wall. You can see calcifications, and I think that everyone can also appreciate that there are mildly enhancing multiple septations within the lesion. And again, this clearly had to be resected, but it turned out to be benign. What about this lesion? It looks a little bit more ominous. You can see a larger, more dense calcification. There are areas around that calcification that look like it's enhancing, somewhat more nodular. However, upon resection, this was also benign, and this turned out to be a cystadenoma. On MR, similar features. You can see on the T2 weighted image that there's layering debris along the posterior wall. There's a more nodular component. And then when you give gadolinium, you can see that there's actual enhancement of that posterior nodular component. And this turned out also to be a biliary cystadenoma, so benign. Now, cystadenocarcinoma is less common than the benign form. And I did want to bring to your attention that there are two different subtypes. When you have ovarian stroma, histologically, obviously we can't tell by imaging, but when you have it on histology, it actually imparts a better prognosis. When you are missing the ovarian stroma, it correlates with a poorer prognosis. Again, on imaging, we look at this case, which turned out to be malignant, and we would predict that because it looks like there's a larger soft tissue component along, especially posteriorly, with some mild enhancement and internal septations. We just cannot tell benign from malignant, and these all should come out. There are mimics of this lesion from benign, complex simple cyst, for example, a cyst that bleeds, a kind of cockle cyst, abscess, necrotic metastases, and hepatocellular carcinoma, when it's cystic in appearance, can simulate this lesion. And I'll show you the initial image and see if you can find a lesion. It's not easy, but when I show you the follow-up CT a year later, you definitely see a cystic type lesion. There is an enhancing nodule along the wall, and this actually turned out to be a cystic hepatocellular carcinoma. So on the latter image, it certainly looks like it could be a biliary cystadenoma or carcinoma, but this was a cystic HCC, and I think that you can see a hint of it on the initial image. Okay, focal nodular hyperplasia. We all know that most commonly occurs in women. Although it only affects 3% of the population, it is still much more common than adenoma. So in your differential diagnosis of enhancing lesions of the liver, just remember that FNH is much more common than adenoma as one of the facts that will guide you in your differential diagnosis. The majority, 80%, are solitary, and most of them are under 5 centimeters in size. Now remember that these are composed of hepatocytes, and they do contain Kupffer cells. So there will be normal uptake on technetium sulfur colloid scan. 60 to 70% will have a central scar, and these scars are special because they have vascular channels. There will be delayed enhancement, and this will be one of the differentiating factors that can help you to distinguish FNH from other lesions. We'll talk about that later, that have central scars, like giant hemangiomas and fibrolamellar HCC. Now let's talk about the enhancement pattern of FNH, because it's quite interesting. So On the non-contrast image, FNH tends to be isodense to the liver, so you can't even see it. On the arterial phase, they tend to enhance fairly quickly to their hypervascular, obviously, and homogeneous enhancement. If they're larger, you may see the scar, but they tend to fade as you move into the portal venous phase and will become isodense to the liver again. As I mentioned before, that scar, if you do see the scar, has vascular channels in it, so there may be delayed enhancement. One other teaching point is that they may actually have these tortuous vessels that lead to the lesion. And so you look for these in the arterial phase. So here's a patient with an FNH, and you can see on the delayed phase that it just completely fades. Now there is a scar centrally, hard to tell on the delayed phase. And here's another one posteriorly, and again, it shows a fade. Aberrant, or these sort of tortuous vessels on the arterial phase, you can see hyper enhancement, so immediate enhancement. But look at that very tortuous vessel that leads to the lesion. And again, on the CT, very similar to the MR I showed you, the enhancement just fades away, although you do still see that central scar. Here's another one with that aberrant vessel, immediate enhancement, very homogeneous, and then the fade into isodense to the background parenchyma on the delayed phase. Now, 20% of lesions will have a non-enhancing scar. In fact, the cases that I just showed you, several had scars and they were not enhancing on the delayed phase. If you have a lesion with a scar that shows on the arterial phase, and then you lose that scar on the delayed phase, is because that scar actually has vascular channels and it's just filled in with contrast. So here's a patient who the lesion you can see is isodense on the non-contrast image. You really can't pick it out. Hypervascular on the arterial phase, and then it fades and becomes isodense. And we really don't see a scar. So this occurs in up to 20% of patients. And just as a review slide for you of the whole scar enhancement patterns, the majority will have delayed enhancing scar. 20% will have non-enhancing scar, and then up to about 20% will have no scar at all. Okay, let's talk about adenoma. These represent a benign tumor comprised of hepatocytes. They are associated with oral contraceptive use in women and with type 1 glycogen storage disease. You can have multiple of these, in which case patients may be symptomatic and prone to malignant evolution, and this is in an entity called adenomatosis. What are the imaging findings? Well, again, these are hypervascular. That's why often they may be confused with FNH. So 90% are hypervascular. They do not contain Kupffer cells, and that's why we use technetium sulfur colloid to help differentiate sometimes adenoma from FNH. So they're cold on technetium sulfur colloid scan. 30% of these may demonstrate hemorrhage, and I have a case to show you later on. Again, they can mimic FNH, but of note, these will not have a scar. But remember that up to 20% of FNH lesions may not have a scar. So here is a typical adenoma. When you look at it on just this one image, certainly could be an FNH without a scar. Here's another adenoma. This was a 28-year-old woman who was on oral contraceptives. Now, on the arterial phase, you can see immediate homogeneous enhancement, and then becomes hypo attenuating on the delayed phase. So not so, the FNH typically is more isodense and fades, whereas the adenoma you can see is more hypodense. What about on MR? So on T1, typically hypointense, somewhat heterogeneous. Arterial, you can see at the immediate, fairly homogeneous enhancement. And then on the early portal phase, you can see that starting to become somewhat iso, and then on the later portal actually becomes hypointense. On the hepatobiliary phase, when you give EVIS or Primovis, you can see that it is hypointense. There is some peripheral still hangs on to contrast and appears more heterogeneous. And this is the typical appearance of adenoma. Now, I said that about a third will demonstrate hemorrhage, especially when you have multiple of these. This patient actually had several adenomas, and you can see actually a hematocrit level in lesions. So remember that these lesions can bleed. Lipomas should not be an issue for you. These are uncommon. They are discrete lesions of fatty density on both CT and MR, and obviously no enhancement. The only problem will be an ultrasound where they may be mistaken for hemangioma because they will have echoes. And here it is on CT again, so fatty density. I think what's more problematic is probably the angiomyolipoma. You can see that in this particular lesion, and besides fat, it has other components, smooth muscle and vessels. So they can sometimes have portions that do enhance. It can look more ominous. They are similar to kidney AMLs, and they do occur in up to 10% of patients with tuberous sclerosis. But when you look at this, the fatty density should be a tip-off that it is an angiomyolipoma. I think what's more scary is when you have these lesions and you don't have fat, in which case you'll have something that can look identical to HCC. And then the management would be that it's an HCC until diagnosis is excluded. Lymphangiomas are interesting lesions. They represent dilated lymphatic channels, and these are multi-organ lesions that can affect the spleen, the bone, the lung, and even the brain. You can see that on the CT image that this lesion looks like a large lobulated cyst or multiple cysts clustered together. They are fairly well defined. They do not enhance, and also note that they can bleed. And here's a patient with multiple of these, and this was lymphangiomatosis involving both the liver and the spleen. And here's an extraordinary case that I had of a patient with lymphangiomatosis, and pretty much all of them show hemorrhage. Okay, so I have pulled together this sort of algorithm chart to show you and to go with you to help you in your differential diagnosis. When you see a focal liver lesion with fat, you're going to think about lipoma or AML. For cystic lesions, based on size, if it's small and multiple, you're going to think about bile duct hamartomas. Think about that when you see the starry sky appearance, you're thinking about these hamartomas. Microabscesses in patients who are immunocompromised in particular, and then you can have multiple just small cysts. When you have large cystic lesions, yes, it could be a giant cyst, but think about biliary cystadenoma. Again, it could be cystadenocarcinoma. We just cannot differentiate on imaging alone. But lymphangioma, less common cause of large cystic lesions, and then obviously abscess in the correct clinical situation. What about soft tissue lesions? If they demonstrate homogeneous enhancement, you're thinking about the smaller hemangioma, flash-filling hemangiomas, FADs, which are typically subcapsular, so peripheral in location, wedge-shaped, and associated with a variety of lesions. FNH and adenoma, obviously, as I reviewed. Heterogeneous enhancement, you're thinking about giant hemangiomas without complete fill-in. Pileosis hepatis, which has an opposite enhancement pattern of hemangiomas. Then you can have the angiomyolipomas without fat that simulate HCC. So this is just sort of I think, an easy chart that can help you in your differential diagnosis based on what you're seeing on the image. And then after we review the malignant focal hepatic lesions, I'll put that on this chart as well. And these are the lesions that we'll talk about for malignant lesions. So let's start off with metastases. And after lymph nodes, the liver is the most common site for metastases. And obviously we know that most of them are hypovascular. We've all seen these appearances. Now, there are specific primaries that will cause hypervascular metastases that you should know about. And these include neuroendocrine tumors, thyroid carcinomas, sarcomas, renal cell carcinoma, and melanoma. And here's a patient, nice demonstration of multiple hypervascular metastases, and this was due to melanoma. And here's a patient with several hypervascular metastases due to thyroid carcinoma. Now, metastases can also be very cystic in appearance, and this is the list of primaries that can cause cystic mets. You can just read them here, but what I have demonstrated are two different patients, one with metastatic breast carcinoma and one with ovarian carcinoma. I did want to bring to your attention, though, that mucinous type lesions more often will show these very cystic type metastases in the liver. So think about colorectal and ovarian carcinomas in particular. And here's a patient with metastatic ovarian carcinoma. But note also that there is a thicker enhancing rim to these lesions, and look at the periphery. It's very irregular and somewhat jagged almost along portions of the wall. What about this patient on T2 rated MR? You can see multiple small T2 bright lesions. You're not going to confuse them for hamartomas or cysts. Why? Because you see this large left renal cell carcinoma, right? So these were cystic metastases due to renal cell carcinoma. You can have calcified metastases also, and these are typically from mucinous type tumors, so also from colorectal carcinoma. Primary and ovarian carcinoma can cause these, and this is just very nice demonstration of that. Moving on to lymphomas, these are interesting because they can cause, they typically cause multiple lesions scattered throughout the liver, often affecting the spleen as well, with splenomegaly as we see in the top image. But they can be more hypo-attenuating, or you can see the top image shows some that almost appear cystic. And then you can see these somewhat larger lesions, also hypo-attenuating, but certainly not as low as what you would see for a cyst. The secondary lymphomatous lesions are more common than primary, and more commonly seen with non-Hodgkin's lymphoma than with Hodgkin's disease. Other features, obviously, that you're going to look for are adenopathy and, as I mentioned, splenic involvement. Here's another patient. You can see biliary ductal dilatation in association with several large central hypo-attenuating lesions, and this was all due to lymphoma. Okay, now we're going to move to sort of a very substantive area, which is hepatocellular carcinoma. This is the most common primary hepatic malignancy, more common in men. Cirrhosis is sort of a baseline that we see in most patients. What are the risk factors? Well, obviously hepatitis B, but hepatitis C as well, particularly in the States. Alcohol use, and then non-alcoholic fatty liver disease is now recognized as a significant risk factor for the development of HCC as well. The survival rate is actually quite poor. And you can see 5-year survival at less than 20%. What we do have to be aware of is that I think the larger lesions are really not as much of an issue for us to diagnose as radiologists. However, it's the small lesions, those that are under 1.5 or 1 centimeter, where irrespective of whether we're using contrast-enhanced CT or MR or ultrasound, there's still suboptimal sensitivity and specificity. And many of you are familiar with this diagram of the progression from the generative nodule to a dysplastic nodule, develop a focus of HCC, and then it just becomes from the small to a larger lesion. And I did want to also show you that we know that there are 2 distinct molecular subclasses of HCC. The genomic features divide them into a proliferation subclass and a non-proliferation subclass. The one that you don't want is obviously the proliferation class, because this is associated with chromosomal instability, and you can see the mutations associated with this class. These are also the class where patients will have hepatitis B infection. They tend to have high-grade tumors, high AFP levels, and a worse clinical outcome. The non-proliferation class, you can again see the mutation, the CTNNB1 mutation is associated. There is the association with hepatitis C infection and alcohol use. These tend to be lower grade tumors, and less frequent is vascular invasion with a better clinical outcome. Now, how do you handle HCC? I think it really is somewhat site-specific, but this is from a New England Journal of Medicine paper on surveillance. And the recommendation here is ultrasound every 6 months, irrespective of AFP level. They do show a sensitivity that is can range lower than for CT or MR. A sensitivity wide range, 47 to 84%. And we know that ultrasound is more operator dependent. And I think that that leads to this broader range of sensitivity and why it can be have a lower level range of down to 47%. High specificity. Contrast enhanced CT or MR can also be used, and you can see the sensitivity here as well, ranging between 66 up to 82% with high specificity, and obviously less operator dependent compared to ultrasound. And I know that, at sites where it's difficult to obtain CT or MR, ultrasound, is relied on as what you will use as the imaging technique to perform surveillance for HCC in high-risk patients. I did also want to show you, and certainly this could be, multiple talks on its own, is the LYRADS categorization schema. And I've given you some resources. The ACR website is very thorough and complete, and I refer you to that. There's also a great paper published in Radiology by Dr. Cherniak, also on the updated 2018 LYRADS version. But this is and everybody's aware or should be aware of the ACR RADS system that's used for multiple organs, but this is specifically for the liver and for patients with cirrhosis and HCC. If you look at what I have shown here, LR1 is a definitely benign lesion, LR2 probably benign, LR3 is intermediate probability of malignancy, LR4 probably HCC, LR5 is definitely HCC, and then the TIV is tumor in vein. So clear descriptors, I'll show you this, which has more criteria for CT and MR. This is all on the ACR website, and this is meant to, I think, standardize and provide us with terminology that we can all use that is uniform and will help for clinical cases, but also for research. So we recommend the use of LYRADS, and I think that there's a great resource for you on the ACR website. Okay, this slide shows you, and I think you're very familiar with this, the classic enhancement pattern for HCC, where on the early arterial phase, you can see that there already is some enhancement of this lesion, and then hyper-enhancement on the late arterial. You can even see an artery leading to it, washout on the venous phase, and then a hypoattenuating lesion on the parenchymal phase. So clear hyper-enhancement leading to this gradual washout. On MR, again, very similar arterial enhancement with the venous washout. When you see this, think about HCC, obviously. What about the appearance on the hepatobiliary phase with eovist or primavist? Should be hypointense. And again, when you combine the arterial, venous, and HPP phase, you're going to call HCC for this. And more literature is coming out, especially over the past year or two, that using eovist or primavist on MR, it actually gives you higher sensitivity than contrast-enhanced CT for the diagnosis of HCC, particularly for the smaller lesions under 2 centimeters. And I've given you 2 references here. One is actually a meta-analysis of 8 other studies, and all of them show that we probably should be moving to using eovist and primavist for these, particularly the smaller HCC lesions. Again, these are the classic enhancement features, hypervascular. They can be heterogeneous due to necrosis, internal bleeding. Some can have calcification, and then some can actually contain fat. A capsule is classic, that occurs in about 60%. Associated with portal vein thrombosis in about 40%. They can be fairly aggressive and invade adjacent structures. And here's just a larger lesion, very heterogeneous in appearance, and you can see hemorrhage and calcifications. And here's another one that shows actually tumor invasion. So the portal vein branches, you can see, are all thrombosed. HCC can also be infiltrative, and we have to be aware of that. You clearly see ascites and irregular contour, but this is not just cirrhosis. When you look, you can see the caudate, other parts of the left lobe, there is clear infiltration. This was due to HCC. Now, you're looking at the main liver, and you can see very cirrhotic liver, irregular border, lumpy, bumpy border, but there is an HCC here. And you can see that these can be somewhat exophytic, so make sure that you look at all parts of the image. There is a category of HCC, the fibrolamellar HCC, that occurs in younger patients in their 20s, not associated with cirrhosis. These patients typically have normal AFP and carries a better prognosis than the typical HCC. Again, you know, the hypervascular appearance, but these tend to be very large, so greater than 10 centimeters. Calcifications are more common, and these may have a central scar. Although these are non-enhancing central scars, they may show some delayed enhancement, but not as commonly as with FNH. And here's a patient with just a giant heterogeneously enhancing lesion, central scar. This turned out to be a fibrolamellar HCC. And I think this chart is very helpful. It shows you some of the key features that will help you in differentiating the various lesions that have central scars. So the 3 to remember that have central scars are FNH, giant hemangiomas, and fibrolamellar HCC. What will help you for FNH is that the majority often will have delayed enhancement of that central scar. For the giant hemangiomas, the classic enhancement pattern obviously will be of help to you. And then for the fibrolamellar HCCs, they tend to be larger than both FNH and giant hemangiomas. Not always, but they can have the calcifications. If you see calcifications in a patient with a central scar, think about fibrolamellar HCC. I think that this is a very helpful chart to distinguish these three lesions. Okay, moving on to cholangiocarcinoma. This is the second most common malignancy of the liver, and there are various causes, including PSC, so primary sclerosing cholangitis, Crowley's disease, can be associated with choledochal cyst and thorotrast use from the past. We're all familiar with the imaging features. They tend to be hypoattenuating on CT. And what is classic is this delayed enhancement. So you have to think about it and perform at least at 10 minutes, a scan. Biliary ductal dilatation, and then you want to follow it centrally to see if you can find the mass. Often associated with capsular retraction and then lobar atrophy. So here's a patient on the venous phase. Actually, you can see appears hypoattenuating, but you can see some biliary ductal dilatation, and then on the 10-minute delay, you can see that the lesion shows delayed enhancement, and this was a cholangio. Here's another one. Hard to see, I think, on the first image. You do see the biliary ductal dilatation. You follow that dilatation centrally, and then you do see a mass with some mild enhancement. So always look at the apex of the ductal dilatation for the mass-like lesion. Capsular retraction, as I mentioned, is a feature, but you can see in other lesions. We're going to think about cholangiocarcinoma probably first, because that's sort of what we're taught. But then other lesions such as metastases, fibrosis, an infarct can also retract the capsule, and then a particular vascular tumor, epithelioid hemangioma, although I would put that at the very, very bottom of my list because it is so uncommon. And again, top of the list, if you see capsular retraction, I would always think about cholangiocarcinoma. And this is that same chart that I showed you earlier for benign lesions, and I'm going to superimpose now the malignant lesions. So fat-containing lesions, I've added in hepatocellular carcinoma. Not a common feature, but can occur. For cystic lesions, obviously you can have cystic mets. So I threw that in there for both small appearing cystic lesions as well as larger cystic lesions. Under soft tissue lesions, non-enhancing lymphoma, again, typically multiple hypoattenuating lesions scattered through the liver. You're going to look for associated splenic involvement and adenopathy, but these tend to be non-enhancing. Homogeneous enhancement. Metastases can do anything. So often they're listed throughout all these differential diagnoses. Small hepatocellular carcinomas will enhance, but it'll be very homogeneous in the cholangiocarcinoma with delayed homogeneous enhancement. What about heterogeneous enhancement? Again, metastases can cause anything, so we threw that in there. And then we have hepatocellular carcinoma, as I showed you many cases where you can have internally necrosis, and that will cause heterogeneous enhancement. And obviously for fibrolamellar HCC, you can have the central scar, and again, heterogeneous enhancement. So I think that this last sort of chart is very helpful for you in looking at the various features of focal liver lesions and the differential diagnosis. So in summary, what are some of the key points that I want you to take away from this is that the transient hepatic attenuation differences are benign, but they can indicate tumors. So when you see them, don't discount them. They are subcapsular, they're wedge-shaped, and look and see whether you can see an associated mass, because HCC can cause that, as well as benign tumors. There are specific signature enhancement patterns that you need to know about. I've pointed this out several times, which is that the FNH can have a central scar. Delayed enhancement of that central scar is a feature. So if you see that, you're going to think about FNH. The flash-filling hemangiomas can be hard to differentiate from small HCCs because they're going to enhance it immediately, they're going to be homogeneous. However, look for that persistent delayed enhancement versus smaller HCC, which should show some washout. So persistent delayed enhancement will help you for the flash filling small hemangiomas. And then just remember to put higher on your list what's most common. And when you have these homogeneously enhancing lesions, and you're thinking about, is it FNH, is it adenoma, just remember that FNH is much more common than adenoma. And unless it's a woman on oral contraceptives, then you think more about adenoma. But otherwise, think about FNH because it is much more common. And then, if you see bile duct dilatation, you always want to follow the lesion centrally to its apex to see if you can find either on the earlier phase, but particularly on the delayed phase, a mass. And on the delayed phase, if it's enhancing, you're in particular going to be thinking about cholangiocarcinoma. So I think that is my last slide. Thank you so much for your attention, and I hope this was helpful for you.
Thank you, Dr. G. This was an excellent talk and very educational. I'm sure everyone really liked it. We have one question from Dr. Fatima Ali Umar from Muhimbili University in Tanzania. The question is, how do you differentiate biliary cystadenoma from abscess?
So the biliary cystadenoma, and again, knowing that you can't differentiate it from the carcinoma, right? So it's really benign, could be benign or malignant from abscess. Abscess tends to have a more continuous, thick rim that enhances. And often you'll see some compression and enhancement of the liver around an abscess. Obviously, the clinical situation will help you as well. Remember that biliary cystadenoma / carcinoma is more common in women, and they only become symptomatic when they're fairly large. So I think that will help you.
Okay, that's excellent. Thank you so much. We have one more question from Momema Isam from Djibouti, Africa. How can we differentiate between hemangioma and angiosarcoma radiologically if the second was well defined with similar enhancement pattern?
The answer is that you can't, right? Because angiosarcomas can really look like a hemangioma. Obviously, if you have a lesion that doesn't completely fill in and is completely just peripheral, I would be thinking more of angiosarcoma. Hemangiomas, for the most part, the far majority of them will fill in, maybe not completely, but close to the center of the lesion. Whereas angiosarcomas that I have seen that simulate hemangiomas will show that peripheral globular enhancement pattern, and they don't really fill in a whole lot. So I count on sort of more the delayed phase to show me that the lesion truly is indeed having gradual filling.
Perfect. That's really helpful. We also have thank you from Dr. Ernesto Javier Espinoza from Mexico, who says, excellent conference with very good clinical cases. Congratulations and thank you very much. And Dr. Enrique Menero from Mexico and Dr. Mumina Assam from Egypt. We have a physician from University of Rwanda who would like to say a few words. You can go ahead right now.
Hello.
Hi.
Hi, please go ahead. Yes.
That's a nice talk. Thank you very much for the talk. I'm Dietone. I'm a PGY2 resident in radiology. And this is the program, the new program in the country, in Rwanda. The first people are in the fourth year. There are 3 in fourth year, final year. And me and the other 2 colleagues, we are in the second year, so they skip 1 year to get another intake. This was very interesting. Thank you, Bavia, for your effort to give this access for residents, especially radiology residents, to get those knowledge. And I would like to ask just one question. It is about the follow-up of cystic meds. Sometimes we get patients who are on radiotherapy and they have cystic liver, mets, and the oncologist will come and asking, how can we know that this cystic mass is responding to the chemotherapy? It's not still active or not active radiologically. How can we answer that question? Thank you very much.
So if I can repeat the question to make sure that I have it correct, is that how can we be sure that when you have multiple cystic lesions, and the concern is metastases, that these are indeed cystic metastases?
Just when they are on radiotherapy, then they are doing radiotherapy for those cystic mets. They want to know if they are still active or non-active, or if they responded to the radiotherapy.
Okay, so there are a couple of ways I think that you can approach that. And in comparison, obviously, to the baseline pre-therapy images are going to be key. What is the change? You know, oftentimes we see increasing necrosis. Sometimes you see evolution of calcification in treated metastases, right? But are they still active? It's a very hard question. Some have used PET CT or even PET MR to see if there's, and what's helpful is if you had a baseline PET CT or PET MR to help show you the degree of activity, right? So if you're fortunate enough to have that, I think that that's what I would use. Decreasing size, obviously, is a tip-off that they are responding, but they still may be active. I don't think that outside of having a functional exam that you can truly say that, you know, if you still see the lesion and you don't see clear decrease in size or evolution, that you can say that it is no longer active. And it may come down to if it really is going to change management, but often it doesn't. But if they say that it's going to change management, is actually to do just biopsy a specific lesion. But that only will tell you one part of, you know, the liver and the lesions. So again, it's a tough question.
Yeah.
Thank you so much, Dr. Yi, and thank you, Dr. Didon, for asking this question. We are very proud of radiology residents at University of Rwanda, and they're leading the change because it's the first radiology residency program in the whole country.
Wow, so, fantastic! Yes, congratulations. That's great.
Very, very passionate and intelligent radiology residents there. I think we are running up the time, so we do have a few more questions which I can send to Dr. Yi later, so that, you know, we don't want to keep her for too long. But Dr. Yi, thank you so much. We really appreciate you doing this for us, and we are getting a lot of good presentations and thank yous right now from radiologists in different parts of the world who really appreciate your talk. Thank you so much, and we appreciate this, and you have a great day. Thank you.
Thank you so much. It's my pleasure.
Thanks. Thank you. Thank you, everyone, for joining us today. See you next time.
Okay.